Okay, so some people wanted a video kind of explaining some of these topics because it makes it easier than just having to read through it all. So I will do my best at explaining some of these things. So we'll go through basically what notes he gave us, and I kind of just wrote out all of the answers to the notes that he gave us. So starting with like structures of the heart. So looking at chambers. So beginning with chambers, we have the atrias and the ventricles. So we'll have two atriums. We have the left and the right. And the right side will always contain your deoxygenated blood. So that's where your veins are going to enter into the heart, and that's why it's deoxygenated. Um, and then you have your left atrium, which is going to contain your oxygenated blood, because your left atrium is going to be getting its blood straight out of the lungs, so it'll be freshly oxygenated blood. Your ventricles, so as I said, you have two ventricles. You have your right ventricle, which also has deoxygenated blood. The right side of the heart will always have deoxygenated blood because it's coming from the veins. It hasn't reached the lungs yet. So that contains your deoxygenated and move blood to the pulmonary valve. So it'll move through the pulmonary valve out of the ventricle, and through the pulmonary valve, it'll go into your pulmonary trunk, then your pulmonary arteries, and then through your pulmonary veins back into your left atria, through the bicuspid, and then into the left ventricle. So your left ventricle will be oxygenated blood because it's now ran through the lungs, so now it has oxygen and it's ready to move to the body. And your left ventricle will move the blood through the aortic valve into the aorta so that it can be distributed through the body. So looking at our valves is the next structure that we need to be concerned about. There are actually four valves. So we have the pulmonary valve, and this valve lies between the right ventricle and the pulmonary trunk. So the right side contains two different valves. The first one that you're going to be thinking of is if you're going from right atria to right ventricle. In between those, you're going to have your tricuspid valve. That's your first valve that you'll run through. And then after that, you're going to be going to the pulmonary valve. And that's what lies between the right ventricle and your lungs, essentially, is your pulmonary valve. So moving through that, your next valve that you're going to run to is actually your bicuspid valve. And I don't know if on the exam we'll need to know the name mitral valve, but it could be on there, and it's good to know. So that valve is the one that lies between your left atria, which is the one receiving the blood from the lungs, and the left ventricle. And then our final valve that we have to worry about is the aortic valve, which is appropriately named because your left ventricle is going to be pushing blood through the aortic valve to get to the aorta to disperse it to the rest of the body. So your aortic valve lies between the left ventricle and the aorta. So, and then that's it for pretty much the interior structures that we need to know. Looking at the layers of the heart, there are three layers to the heart from outside to in. The epicardium is the most outer layer, and then the myocardium, which is more like the muscular layer, and then the endocardium. And I'll explain what each of those is. The epicardium, otherwise known as the visceral layer. So visceral layer is what we learned in our labs. That's the outer layer. Prevents overexpansion or movement of the heart. So that just basically it prevents the heart from detaching from where it's located in the body. And it also prevents the heart from expanding too much and, basically exploding. The myocardium initiates contractions, driving the cardiac cycle. So that's basically the musculature of the heart is the myocardium. And then the endocardium lines cavities and valves on the interior of the heart. So that's basically your innermost layer. That's kind of just protecting the inner cavities and valves on the interior heart. That's pretty much the structures. We'll go through the next page here. So now that we know kind of the structures of the heart, we'll look at the cardiac cycle. So this will begin with the firing of the SA node, and the SA node is essentially what initiates the beating of the heart. So that's what you can think of. It initiates the start of the contractions of the heart. This will cause both atria to depolarize or contract. So depolarize and contraction are the same thing. So whenever Dr. Hopkins is saying something is depolarizing in the heart, that just means it's contracting. And that means the same as well for repolarizing. Repolarizing means relaxing. So basically, contracting is depolarization and relaxing is repolarization. I think understanding those two terms would help you better understand this. So beginning with the firing of the SA node, this is also known as the P wave on the ECG, because the P wave is the contraction of your right atria. Well, both atria, actually. So your first little P wave that you see, so actually looking down here, this P wave right here is actually contraction of your atria, but the way they're going to ask it is they're going to say, what type of polarization is this? And so it's going to be your depolarization of your atrias. So the bicuspid and tricuspid valve open to allow blood to travel to the ventricles. So basically, you have to think about what valves need to be open when something is beating. So if your atrias are the ones that are contracting, meaning they're pushing blood through the heart, they need to go through the two valves that allow them to enter the ventricles. So if you're thinking about the heart, they're going to go through your tricuspid on the right side and through your bicuspid on the left side to travel into the ventricles so that the blood can then be compressed out of the ventricles into the body or into the lungs. So the next step after your firing of the SA node and your depolarization of the atrias is the ventricles fill with blood but do not release the blood. So there's a slight delay period in between the atrial contraction and the ventricular contraction. And this is known as isovolumetric contractions. I'm not sure if we'll need to know that term, but it's good to understand that this is where ventricular depolarization, so remember, ventricular contraction, and atrial repolarization, so atrial relaxation, begins. So it's not the complete process, but it is where it begins, and that's your QRS complex. So your QRS complex is the depolarization of the ventricles and the repolarization of the atrias coming all the way through full cycle. But this is where it begins. So it begins with the ventricles filling with blood, but then not releasing quite yet. And this is prevented by the AV node, but we'll get into that. The ventricles fully depolarize once they reach enough pressure. So the pressure in the ventricles becomes greater than the pressure in the atrias, and that will open the pulmonic and aortic valves. So if you remember talking about those valves, the pulmonic valves leads to the lungs, right? And the aortic valve leads to the aorta. So those valves will open, allowing for an escape for the blood from the ventricles. So those ventricles will then squeeze the blood into the pulmonic valve to send it to the lungs and into or through the aortic valve into the aorta to be dispersed to the body. So, and this is known as rapid ejection. So this is known as, basically, you can think of it as this pressure builds up and then it quickly guns out of the ventricles through the valves into the lungs and the body and the aorta. And so it's rapid ejection. And then finally, so that's our QRS. Finally, there is a repolarization of the ventricles. So the repolarization of the ventricles is the relaxation of the ventricles. So after that burst that it ejects out, they have to relax now to reset for the next contraction. So, and this is known as the T wave. So our P wave, right, is our depolarization or contraction of the atria. And then our beginning of our QRS is the repolarization of the atria, so the relaxation of this to reset it. The depolarization of the ventricles, so now the ventricles are starting to contract. And then we have the T wave, so that repolarizes the ventricles. So now the ventricles are nice and relaxed. This is already relaxed. Our atrias have already relaxed again. So now the heart is ready for its next beat. And then we'll just repeat this whole process. And that's the cardiac cycle. So to quickly go through it, it's the SA node firing to start the action sequence. It's both of the atrias contracting. And then our QRS is the ventricles then contracting and the atria relaxing. And then the ventricles relaxing. And then a reset of that. But understanding that when your atrias contract, your tricuspid and bicuspid valves are opening. And when your ventricles contract, your pulmonic and aortic valves are opening is important, and he's going to ask us about that. And just know what your waves represent, which we've gone over, so we should understand that. So looking down here at our ECG strip that I've wrote up here, our PR interval, and this is 0.12 to 0.20 seconds, is our normal time that elapse while this action sequence is taking place. And this is the depolarization of the atria. This is the amount of time it takes for that normally. The QRS complex should be less than 0.12 seconds. And that's kind of, just matches with that name, rapid ejection, because it's quick. It's very fast. The ventricles fill and then depolarize and then start the repolarization process, being the T wave. And so our QT interval is 0.34 to 0.43 seconds. So the way you can remember these times, I know some people were having a hard time remembering these values. Our PR interval, starting off the wave, is 0.12 to 0.20 seconds. This is the medium value. So this is the second longest period of time. The QRS complex is very fast, right? It comes to a sharp point and then it declines very quickly. So that's our shortest time span here. So that will always be the smallest amount. And the only values that you really need to remember is 0.12 and 0.43. So you know that in that range, all of these things are happening, correct? Okay. So we know that this one is the medium value. We know the next action is the smallest, and that the Q to T is the longest. And what you notice down here, something easily to remember, if you can remember 0.43 or you can remember 0.34, you'll be able to get the other number because you just have to know it's the reverse. So for your QT interval, you really only need to understand 0.43 or 0.34. And you could even say QT is 0.43, and then you'll understand that the first part is 0.34 because they are just reverse numbers here for this time elapsement. So you know that this is the greatest interval, the highest number, the greatest amount of time that takes place between your Q and your T, right? Because they're the greatest distance from each other. Your QRS is your smallest, right? Because you are going from Q to S, and it's a very sharp point and very sharp decline. It's very quick. And your PR interval, which begins everything at 0.12 to 0.20. We'll move on from that. So now we'll look at the conduction system, which is more about basically the electrics of the heart. So our conduction system, looking back at the SA node again, is the beginning of the cardiac cycle. So that's that signal to start the beating of the heart. The AV node is what I was discussing, that stops the ventricle from contracting immediately after the atria contracts. And what that does is it gives time for the tricuspid to close so that you don't have any backflow. And it also gives time for the ventricles to fill with fluid so that they can reach a greater pressure than the atria so they can then eject. So the SA node is the beginning of the cardiac cycle. That will always be the beginning of your beats that will start. The AV node then slows the signal to create extra time for the atria to depolarize. So that's what I mean when I'm talking about the pressure shift from the atria to the ventricles. Is that AV node is basically just slowing down the action so that the atria has time to fully empty and the ventricles have time to fully fill so that they can then eject. The AV fibers or Purkinje fibers create the release of ventricular contraction. So once the AV node slows everything down, the ventricles will reach a point where their pressure becomes so great that they need to release. And that is done so through the signaling from the Purkinje fibers. So then we look, and that's it. That's all you need to know. So the SA node to the AV node to the Purkinje fibers. So now we're looking at another aspect of the heart, which is cardiac output that we need to understand. And I wrote it here as SV times HR. This is stroke volume times heart rate. And so we know what heart rate is, but a lot of us do not understand what stroke volume is. So I will talk about that. So cardiac output is stroke volume times heart rate. Cardiac output is the total volume the heart releases per minute. So when you're thinking about cardiac output, you're just thinking about how much blood is the heart pumping per minute. Stroke volume is the amount of blood exiting the heart per ventricular contraction. So think about how much blood per squeeze of the heart is coming out of the heart. That's what you have to think about. So how much blood is the heart ejecting into the aorta per ventricular contraction? And then heart rate is how many times the heart grows through a cardiac cycle per minute. And so we all know this. It's easy to find people's pulses and understand what heart rate is. So I don't think I need to explain that too much. So just knowing that stroke volume, so that's the amount of blood that the heart's pushing out, times the rate that the heart is pushing that amount out. So it makes sense when you think about it like that, right? This is the amount of blood that's being pushed out. And this is how many times that amount is being pushed out per minute. And they're both per minute. So there you have it. An easy little thought there once you actually think about it. So there may be questions on our test that what factors will affect cardiac output? And so now that we understand that it is a volume times a rate, we can understand that anything that affects the amount that is coming out or the rate at which it is coming out can affect cardiac output. So factors that can cause a change is blood pressure, because that would affect both the amount coming out and heart rate, whether it increases or decreases, right? Heart rate is a direct factor, right? Because it's one of the things that you multiply. So an increased heart rate is going to increase your cardiac output because you're putting more out. Your blood pressure is going to increase the amount being put out, right? So your two main things that are going to affect cardiac output is your blood pressure and your heart rate. So it's either going to affect the amount coming out or the rate it's coming out. So remember, it's volume times rate. Stroke volume, the amount that's coming out of the ventricular contractions, times heart rate, how many times the heart is beating per minute. So I went ahead and described blood pressure just in case, there are certain factors that they may word it as. So they may word it as this: a sympathetic reaction cause an increase in heart rate and blood pressure. Okay, so sympathetic is your fight and flight, don't forget. Sympathetic, the fight and flight. They also cause vasoconstriction of arteries. That's why you have the increase of blood pressure, because your blood is pumping faster. If you get in a fight with a bear, you're going to have a higher heart rate and probably higher blood pressure as well. Parasympathetic reactions cause a decrease in heart rate and blood pressure. So parasympathetic is where we're sitting normally. This is where at our relaxed state, which is why they can also cause vasodilation. So vasodilation is our blood vessels opening up. So we are relaxed. That is why our heart rate goes down and our blood pressure goes down. But we have to understand that these are going to affect our cardiac output. So if a question is worded to you, how would the sympathetic reactions affect cardiac output? You can say that it would increase cardiac output, right? It would increase your heart rate. It would increase your blood pressure, which is essentially what these two things are. And so it would increase your cardiac output. And the same is true with parasympathetic. It would decrease your blood pressure and it would decrease your heart rate. So it would decrease your cardiac output. So that's probably going to be worded that way on our test. So moving forward, all right, we should all know the blood flow of the heart. I did add a few things here at the bottom, but I'll explain why. So our superior vena cava, right, the main vein draining into the right atrium. The right atrium goes through the tricuspid valve into the right ventricle. The right ventricle then pumps that blood through the pulmonary valve into the pulmonic trunk. Pulmonic trunk flows into the pulmonic arteries into the lungs. Here's how I want you to understand why it's arteries first and then veins. So you always think that oxygenated blood goes into the arteries, correct? That's how it is all throughout the body, except for here. So the reason it is the way it is that the arteries are typically what runs towards the heart. Okay, so yes, they typically have oxygenated blood, but this artery in particular is the only one that doesn't run towards the heart. It actually runs towards the lungs. And so that's different from everything else. So the reason that this one doesn't have oxygenated blood in it is because it is the only artery that runs away from the heart. It runs towards the lungs. So that's why I want you to remember that it goes trunk to arteries, the pulmonary arteries, because this is the only artery that runs away from the heart. Okay, so then you have your lungs, then you have your pulmonary veins running back to the heart. These are the only veins that run to the heart. Or this is the only vein that carries oxygenated blood that runs to the heart, excuse me. Left atrium through the bicuspid valve to the left ventricle. The left ventricle will contract or depolarize, sending it through the aortic valve into the aorta. The aorta will split into multiple arteries. The arteries will turn into arterioles. The arterioles will turn into capillaries. Capillaries will turn into venules. Venules will turn back into veins. And then veins will run back into the heart, and you'll get back your blood flow to your superior vena cava from the upper, your inferior vena cava for the lower. So the reason I wanted to list these right here, these arterioles, capillaries, venules, veins, and then repeat. So these isn't really part of the blood flow of the heart. It's more of the systemic. But it's good to understand that. So your aorta being your biggest artery, of course, and then it turns into smaller arteries. And then those arteries essentially part into even smaller arteries known as your arterioles. So basically these are just a subcategory of arteries. So your arterioles then turn into capillaries. And what capillaries are is a transformation bed where arteries turn into veins. So it goes arteries, so your main giant arteries turn into smaller arteries, arterioles, which then turn into capillaries, which is essentially a site of connection between arteries and veins. So those turn into venules, which are basically very small veins, and then into veins. And those veins run back up into your heart. So I've described each so that you can just better understand the functions of these structures. So you have veins. So veins have thin walls because of low pressure requirements. So veins don't have to move blood very quickly. And so they have very thin walls because there's not a whole lot of pressure being put on them. Arteries have thick walls because of high pressure requirements. So arteries are actually looking to move blood very quickly. You're trying to disperse it all throughout your body. So you're trying to get that blood to the rest of your body as quickly as possible. So you need to have thicker walls for that. You need to have more resistance to increased pressure. Whereas veins, they're kind of lackadaisical. They have thinner walls. They're not too worried about getting that blood back to the heart because there's so much of them, so many of them. So they have less pressure requirements. So therefore, they have thinner walls. Okay. I flip my book here. Okay, so this last part here. So now looking at capillary exchange, and that's what I was talking about, where arterioles turn into veins, and this is actually going to be part of this section on our test. So capillary exchange, arterioles are involved in the release of glucose and other solutes and water out of the arteries into the tissue. So what I want you to understand is the arteries come down carrying hemoglobin, carrying the red blood cells that have oxygen in them. They may have sugar in them, different types of solutes inside of them, and they're going to be released into the tissue from the arterioles. Okay? So from the arterioles, those things are going to disperse into the tissue. Then the arterioles are going to turn into your capillary bed. Okay, so they're transforming into veins. So then you have your venules. So it's going to go arterioles to capillary to venules, don't forget. And the venules, since they have thin walls, remember, they have thin walls, so it's very easy for things to go in and out of them, are involved in the reabsorption of water back into the red blood cells because we're trying to keep as much of that water as we can. So we want that water back into the red blood cells, and that's going to happen in the venules. So the functions from a capillary exchange, all you have to know is that arterioles are the ones that release the materials into blood, the glucose, the water, the other solutes, but that the venules are going to do the reabsorption. And really, what they're mainly going to reabsorb is just water. So some specialties that we need to understand about the heart and about the blood flow system is the hepatic portal vein. And so first you need to identify where it's located. So it's located entering the liver from the GI tract and the spleen. And it carries both large amounts of nutrients and waste that the liver will filter out. So essentially, the hepatic portal vein will carry all different kinds of nutrients that we want dispersed throughout the body. But it also carries toxins and different things that we want to get rid of. And the liver is the center of deciding what is going to be nutrients and what is going to be waste. So the hepatic portal vein is essentially the garbage system in that it carries, or should I say the filtration system, in that it carries both a large amount of nutrients and also a large amount of toxins and waste to get disposed of in the liver. This is a really big one that a lot of people don't understand, which is the fetal circulation. And so really we just want to look at what are the differences and how is the fetus getting oxygenated blood when it doesn't have lungs. So starting with that, the fetal circulation, one of the differences, it has two umbilical arteries as opposed to the one that we have. And so they are extensions of the internal iliac artery. They carry fetal blood to the placenta. So there are two arteries. They carry oxygenated fetal blood to the placenta. The placenta is the location where exchange of oxygen and other substances take place. So the placenta is essentially the meeting place between the fetus and the mother. The umbilical vein returns oxygenated blood from placenta, so from the meeting place of the mother and the child, back to the fetus. So the fetus is getting its oxygenated blood from the umbilical vein. That's what it's traveling from the umbilical vein to the baby. It enters the umbilicus and travels to the liver and then becomes the ductus venosus. So the umbilical vein and the ductus venosus are actually the same thing. It's just that the ductus venosus is a continuation of the umbilical vein from the liver. So starting at the liver, it is now identified as the ductus venosus, but it is the same as the umbilical vein. The ductus venosus drains directly into the inferior vena cava. So the inferior vena cava being a main source of where we get our blood in our heart, right? The foramen ovale then takes this blood and moves it from the right atria to the left atria, bypassing the pulmonary pathway. And so the reason it's bypassing the pulmonary pathway is because we do not yet, in fetuses do not yet have the pulmonary circuits to take blood from the ventricles to the pulmonary circuit back into the atria. They don't have that yet. So what it does is it bypasses the pulmonary circuit by moving blood directly from the right atria to the left atria, bypassing the pulmonary circuit altogether. Now, this doesn't stop all the blood from traveling into the ventricle. So there is some blood that travels into the right ventricle. And that's what the ductus anteriosa is for. It takes remaining blood and transports it directly from the pulmonary trunk to the aorta. So this blood is already oxygenated. We just need it to be dispersed throughout the body. And we also need a very small portion of blood to go to the baby's lungs. Even though the baby is not using them yet, it still needs the oxygenated blood to help the lungs develop. So the ductus anteriosa will take remaining blood that's from the right ventricle and transport it directly from the pulmonary trunk to the aorta. So the pulmonary trunk does not go to the pulmonary arteries like it would in grown human beings. Instead, it goes to the aorta. It goes directly to the aorta to be dispersed throughout the body. So it essentially bypasses the lungs altogether. There is a small portion of blood that does still go to the lungs from the right ventricle, but it's a very, very small amount because if you send too much blood into there, you'll just have a buildup of blood. And that is it for the heart section. I hope that you found the video helpful. If you have any questions, you can always email me or text me, and I will answer them as best as I can. If there's anything that you think I missed, please let me know, and we can add it, and we'll go over it. Thanks.